And thank you all, and welcome to the session number 40, Clinic Management of Fertility Preservation, Clinical and Technical Aspect. I'm honored and excited to be co-hosting this session of the International IVF Initiative. For videos of previous section, please go to ivfmeeting.com. You will also find information about the upcoming session on the same page. Our continued goal is to provide educational opportunities while bringing our community together. So it's great to see so many reproductive biologists and specialists reaching out from across the world to participate in these sessions. So thank you all for logging in listening, and please really ask questions throughout the session. My name is Francesca Gioia Klinger, and I will be co-moderating this session with Dr. Andrea Borini. He is in charge of 9 Point Baby Network, a network of centers specialized in the diagnosis and treatment of infertility and assisted reproductive techniques. So we will have an amazing program for the next 70-80 minutes. So again, please ask questions, and we ask you to use the Q&A section of the conference service and not the chat function. So you will see at the bottom a Q&A session. Some of these questions will be addressed live, so me and Dr. Borini will ask the speakers your question, and those that are not able to have answered live will be in the Q&A section. So now I'm pleased to pass the word to Dr. Filippo Ubaldi. He is chair of the Italian Society of Fertility and Sterility and Reproductive Medicine. Dr. Ubaldi is the clinical director of Genera Centers in Rome, Naples, and Marostica. He has more than 30 years of experience in dealing with couple sterility and art techniques. So please, Dr. Ubaldi.
Thank you, Francesca. Thank you for your very kind introduction. And I'm honored to present and introduce this webinar on clinical management of fertility preservation, where 3 distinguished speakers, Dr. Cirillo, Dr. Codacci, Pisanelli, and Dr. Canosa, will try to address the clinical and technical aspects of fertility preservation. This webinar, thanks to the invitation of Dr. Palmer, has been organized mainly by Dr. Klinger and the Italian Society of Reproductive Medicine, where currently I serve as a president. So let me spend a few words on the introduction of the Italian Society of Reproductive Medicine. The Italian Society of Fertility and Sterility was born in Varenna in 1965, so 55 years ago, founded by Dr. Chiara, the prestigious director of the sterility centers of the Ca' Grande Hospital in Milan. Following his decision, the presidency of the society has always been secured by trusted and well-known professors elected every 4 years. In 1990, the society was renamed Italian Society of Fertility, Sterility and Reproductive Medicine. Throughout these years, all the most important Italian players in this discipline have been active partners and important contributors in developing of the society. SIFES missions has always been to heavily invest in the scientific profile, as it can be seen also comparatively in Italy and abroad from the CVs of the scientific production of the members of the board of directors who have progressively made the history of the society. Since the very beginning, SIFES-MR is the Italian scientific society in the field of reproductive medicine that more than any other has produced training events for doctors, biologists, and other personnel involved in the diagnosis and treatment of couple infertility. For about 10 years, SIFES-MR has been organizing, in collaboration with the University of Urbino, a second-level master in reproductive science and assisted reproductive technique with a theoretical and hands-on approach. SIFES-MR has also inspired as a consultative body social and institutional debates regarding the issues related to human reproduction, leading to laws, referendums, and sentences of the Constitutional Court. Last but not least, SIFES was the only scientific society in the field of reproductive medicine in Italy to be part of the IFFS worldwide. So this is, in a few words, the history of the most important scientific society in Italy that together with the organization, thanks to Dr. Palmer, is organizing this webinar. So now I again leave the floor to Dr. Klinger, please.
Okay, thank you. So our first speaker for today is Dr. Federico Cirillo. Since 2014, he has been working at the Humanitas Fertility Center led by Professor Levisetti. And today he will discuss together with us fertility preservation, present and future. Please.
Good evening to everyone. It's a big pleasure for me to be here talking to you about fertility preservation, the present of the topic and the future. This is me some years ago when I was much more best preserved than I am now, that I am very similar, I think, to the mummy of the Similaun preserved in the ice of the Alps. That is the best preserved mummy of Europe. The fertility preservation is like the universe. I think is an expanding universe, an expanding world. And I think that the things that is expanding much more is that the indication to the fertility preservation are growing much more in these years. The first indication that we have is the oncological purpose. We have to keep in mind that almost the 2% of women will be diagnosed with some kind of invasive cancer by the age of 40. But at the same time, we can have also indications like endometriosis or other kind of benign gynecological pathologies, but also non-gynecological pathologies that can lead to a progressive reduction in ovarian reserve. But in recent years, a lot of authors have speculated about the possibility to elective fertility preservation or non-medical elective fertility preservation. And in some authors recently speculated the possibility that every woman should perform fertility preservation. It can be a little bit sarcastic or contradictory, but it's not. It's based on a good basis. This is the literature supporting these indications. 6 years ago, in the Lancet, Stoop and other authors tried to figure out the basis on the fertility preservation for age-related fertility decline. And if they find out that the ethical issues in this topic are still open, and the cost effective of the fertility preservation for age-related decline is still a big matter of debate. So tonight we are going to focus ourselves, I think, in the fertility preservation indications, more medical than non-medical one. There are a lot of diseases in which the individuals can benefit from the fertility preservation interventions, from the malignant disease of the childhood age to the adult ones, or the majority are for sure the breast cancer, but they are not the only one. At the same time, we have also autoimmune, hematological, and metabolic disease that can benefit by fertility preservation and other conditions. The good thing is that in recent years, a lot of different techniques and tools have been developed to help us in this issue. Starting from left to right, we have the drugs and the techniques that can lead to ovarian protection before or after or during the chemotherapy or the gonadotoxic therapy. We have also the R technique, and I think that tonight in my presentation I will focus my attention on this for two, while other better speaker will focus on other technique. We have the oocyte retrieved with cryopreservation of oocytes or cryopreservation of embryos, the IVM with the cryopreservation of GD, and after that the maturation in vitro. If we just focus our attention firstly on the oocyte cryopreservation, different protocols have been developed in the recent years in order to achieve this goal. And in some manner, these protocols can be very different from the normal protocol that we are using daily with in IVF and in normal in vitro fertilization. We have to keep in mind that the two main goals of the stimulation protocols for cryopreservation, for fertility preservation, are two. The first one, you have to be quick. What does it mean? In a lot of people, in the majority of people in which you have to start the chemotherapy fast, you cannot miss so much time, and you cannot use so much time in waiting to start your protocol. So be fast and be safe. What does it mean, be safe? You don't have to increase the risk for surgical complications and the risk of ovarian stimulation, of hyperstimulation or HSS. The conventional cost at the beginning of the follicular phase may result in significant delay. And so the three main protocols that have been proposed in the recent years are the random stimulation protocols or random start, the luteal phase, and the double ovarian stimulation or duostim. And we are going to focus our attention on these three. The first one is the random start. What does it mean? In this protocol, the ovarian stimulation is initiated at any day of the ovarian cycle, because there is no need to achieve the synchrony between the ovary, the follicle, the ovarian maturation, and the endometrium, because there will be no fresh embryo transfer, so you don't care about the endometrium. The outcomes of the random start are very good and very similar to the classical follicular phase start. Later on, some authors proposed to start the stimulation protocol during the luteal phase. So the ovarian stimulation is initiated between the 15th or the 20th days of the ovarian cycle. In comparison with the classical one, they ended with a higher number of sites collected and top quality embryos. If you think to unite and join these two protocols, you can arrive to the next one. The third one is the double ovarian stimulation protocol or duostim. What does it mean? It means that you have two successive control ovarian stimulation, one in the follicular and the second one in the luteal phase, with two different oocyte retrievals. The first starts during the early follicular phase, while the second can begin the day after oocyte retrieval, but you can also start it up to 5 days after the first oocyte retrieval. The overall duration is not long, is up to 30 days, between 21, 22, 23, but up to to 30 days. It allows to collect a large number of oocytes, but the ideal drug for trigger and the different protocols are very debated and can vary from different hospital and type of population. But as you can see here, the strength, there are a lot of strength and a lot of point of strength for the dual-steam protocol, but at the same time, the length of the duration, the total duration of almost 1 month can be problematic in some kind of oncological patient, for example, in patient with acute hematological oncological issues. It's you don't have so many days to delay the chemotherapy. At the same time, you can also make the opposite. What does it mean? You can start with a luteal phase first, ovarian stimulation, and then with a follicular one. So first, it doesn't. You can decide which is starting first. The groups from Professor Ubaldi published two important papers about the dual-steam. In the first one, they confront not for fertility preservation, but in poor prognosis patient, in reduced ovarian reserve patient. They use the dual-steam in order to maximize the number of oocytes retrieved, and they find out that the competence of the oocytes collected in the two phases were similar. In the luteal phase, they seems to have a better exploitation of the ovarian reserve, but a higher rate of cancellation rate. Dual-steam, they concluded that the dual-steam in the future could be proposed not only a priori, but also post-hoc. What does it mean at the end of the first one, in according to maximize the number of blastocysts. They find they also try to figure out if the oocytes retrieved in the two different phases were capable to achieve good quality and euploid blastocyst, and they find out that there were no differences in the euploid blastocyst rate, either per biopsied blastocyst or the later the later protocol or later technique that I would like to show you is the IVM, the in vitro maturation prior to cryopreservation. It means that you collect immature oocytes from anthracite follicles with very mild. The strength of this protocol is that it's very fast. You use very low dose of drugs. Is very safe and is very well tolerated. It was first proposed for polycystic ovarian syndrome patient, but it's also been used for fertility preservation purpose. At the same time, we have also to say that the latest Cochrane find out that the oocytes derived from the IVM were not as capable as the normal ones, and I think this is still an open topic. Another tool or another technique that we have is the ovarian cortical tissue cryostorage, but my colleague will talk a lot about this. But let's go a little bit farther and let's see the outcomes of the results of our fertility preservation techniques. The groups of EV from Spain compared in this important paper published 2 years ago in Human Reproduction. They compared the patient that cryopreserved oocytes for elective without medical indications with the oncological cancer patient that we see on the right. they find out that there are patients that cryopreserved oocytes for oncological purpose were younger, with a higher ovarian reserve, and they at the end the number of oocytes and the number of vitrified oocytes per patient were higher, and with, I think, very good outcomes. At the same time, if we make a categorization, sorry, for the according on the malignant type and the histology of the different kind of oncological patient. In this paper published by a French group 2 years ago in RBM Online, they didn't find that the malignant type have an impact of the number or of the oocytes retrieved or the maturation rate or so on. And they concluded that the type of cancer did not affect so much the ovarian reserve a priori, and after that the ovarian response to the stimulation. This is our experience published last year in Frontiers. As you can see from the left figure, the number of patients that came to our attention for fertility preservation in oncological patients is increasing. We treated almost 250 patients in these years. Vast majority was breast cancer, quite a young patient, with a median number of oocytes quite good, between 8 and 16 per patient. Among our population, just 11 patients came back to 12 their oocytes for pregnancy, and we achieved 4 pregnancy with 2 term deliveries. If we go to bigger case series than ours, in the case series that we saw before of Cobo in Spain, they in their experience 7.4% of the oncological patient came back to 12 their oocytes, almost 80 patients, and their clinical and fertility and obstetric outcomes were very good. But we have to keep in mind that the oncological patient came back more than 4 years after the storage. That means almost the double of the time of delay of the elective fertility preservation, and also that the outcomes were slightly less as good than the elective fertility population. There are still a lot of open questions. For example, the ethical and cost effective of all these techniques. For example, we have to keep in mind that, for example, in Italy, there is not possible to cryopreserve embryos for oncological purpose, but we just preserve oocytes in this kind of patients. But at the same time, Nicole Noyes, some years ago from New York, she debated that the use of cryopreserved embryos in oncological patients is not as good as you can think, because if we think that a patient will come back after 4 years of the first storage, maybe during these 4 years they can change partner, and they are not so long with the same partner with which they cryopreserve their first embryos. It's also debatable if we can use more strategies at the same time for better results, but also we have to keep in mind that in a lot of patients we don't have so many eggs or so many oocytes in order to cryopreserve oocytes and embryos at different stages or in the same patient. In our experience, we didn't collect so many eggs. We didn't collect more than 20 in the majority of cases, so we didn't have so many eggs to work with. The comeback rate in all the cases series varies between 5 and 10%. This is a very low rate, as you think, for such a big purpose and a big use of work and medical and nursing staff. We still open if we have to put a standardized age limit for everyone, or if it's better to have a personalization of an age limit. It depends on depending on the patient, their previous history, previous child or not. We can conclude if it's better to perform a better selection of the patients, or if the key for achieving a better coming back rate is to better cooperation with oncologists first. To conclude, in Humanitas, some years ago, we built up a group for adolescent and young patients with cancer, in which they can copy with their diagnosis, and they discuss with different specialists the different aspects of their treatment, their future, and their ability to conceive later on. I think that I can conclude. I would like to conclude that fertility preservation is not a one-man or a one-woman task, but is achieved by a group. As here we can see the Humanitas Fertility Center, and here you can see from my chief, Professor Levisetti, to Anna Maria Vaggiani and Dr. Specchia, that are the chiefs of the fertility preservation. But you can see that is a joining group, and for this purpose and this goal, we have to work like a team. Thank you very much.
Good job, Federico. Very good job. So one question is, they ask to you, can an ad hoc dual stimulation protocol have a future in a non-oncological patient, even in those with a normal prognosis? So I think that they need to understand if just because in one shot, you in 1 month, you can have a lot of eggs, is always good to do also in normal responder patient, that if they want to freeze for later time pregnancy.
Why not? I cannot see any negative aspect of the dual stim.
Do you think that is if in the first stimulation she has already, let's say, 12, 15, 18 eggs, that she needs another stimulation? Because
no, I don't think so. I think that it's a very good idea to use it in a poor prognosis patient or in patient with a lower ovarian reserve, in order to achieve more than 10 oocytes. But I don't think that in normal responder patients you can ameliorate so much.
I have another interesting question, I think, is what is the actual percentage of the 2% of oncological patients in Italy who are actually seeking assisted reproduction and cryopreservation? Do you have an idea? Do you have an idea in Lombardia, your region, how many are they? So is very few people, a lot of people? Because you said in your, you pointed out in your presentation that is important the colleague with the oncologist. So is that real or is not real?
I don't have a clear number about this, but we speculate a lot in our center. In Humanitas, there is one of the biggest oncological center in Lombardy, that is one of the biggest region of Italy. And we didn't understand, it's difficult to understand if the key in which you have to work to arrive to a much higher rate of patient if the problem is that the oncologist doesn't trust us, and so the oncologist do not believe in fertility preservation, and so they didn't send us, they don't send us the patient for the first first consultation. If the problem is that the patient don't want to do it, or they are scared about the ovarian stimulation, or they are scared by the delay, I think that there is still a lot of ground to work on this topic.
So now we move to the next doctor, that is Dr. Giovanni Codacci Pisanelli. That is actually, he is an oncologist, so he will speak on that side. And Dr. Codacci Pisanelli specializes in medical oncology, and since 2013 has been involved in onco-infertility, dealing with the fertility preservation in young women affected by solid tumors, mainly breast cancer, and the medical treatment of women diagnosed with the cancer during pregnancy. At present, he is assistant professor in medical oncology at La Sapienza University of Rome. Giovanni, the floor is yours.
Thank you, Andrea. Here I go. I tried it before, but now I got messed all over again. I felt called by Filippo and by the previous speaker, because he was talking about why the oncologist doesn't really call the fertility center. And this is what I would like to talk about. So I will try to discuss the interaction between the medical oncologist and the fertility clinic. But let me start with my conflicts of interest. I work for the University La Sapienza in Rome, but I am also a consultant for fertility clinics. I don't have any other conflict of interest to declare. So whom will I talk about? I will mostly talk about young women, premenopausal women that have cancer, and that have a cancer that requires a systemic treatment. This means that if the woman has, for example, a very thin melanoma and that is cured by resection, she doesn't really fit into my talk. But on the other hand, this tumor must have a relatively good prognosis, because even if we are starting to discuss fertility preservation for women with more advanced diseases, I think this still requires further investigation, because it really becomes a general topic. I will not talk about preservation in girls, and also not about heterologous oocyte donation, because these are different points. As I said at the beginning, I am a medical oncologist, so I will not talk about the technical issues which have already been discussed before. Let me start with this note. If we are talking about a pregnancy after cancer, we must be sure that this has no negative impact for the woman. And this is not such a trivial point, because as I will show you later, for many, many years, there was a really sharp concern that ovarian stimulation and pregnancy itself might be dangerous if the woman had had breast cancer, and especially if she had had hormone receptor positive breast cancer. It has been demonstrated convincingly that a previous diagnosis of cancer in the mother does not affect the prognosis of the woman if she has a pregnancy, and also, as importantly, this will not have any negative effect on the health of the baby. But it is necessary to wait some time, to wait an appropriate time from the diagnosis of cancer, from the end of treatment, before the woman may safely look for a pregnancy, be it spontaneous or the result of assisted reproduction. So this is a paper that has been published 10 years ago, more or less, by Hatem Azim and Fedor Peccatori and Nicolas Pavlidis. These are all gynecologists and oncologists that have been involved from the beginning in the field of oncofertility. That is to say, in the field of considering if a woman that has cancer wants to have a baby, what should we tell her? For many, many years, the topic has really been ignored, just ignored. There may be some problems about this. Probably cancer was really a frightening word. It is still today, but I will show you perhaps a bit less than it used to be. The women did not dare to ask about a pregnancy to their oncologist because they were too scared. And on the other hand, they thought that this was a trivial subject, that it was a topic that should not be discussed. They were almost sure that any question in this sense would be dismissed as if it was just a stupid request. But also another aspect is that generally women that were fighting cancer generally already had children. And so the problem of fertility preservation was not as a hot topic as it is today. But this point is becoming more and more relevant for many reasons. First of all, the prognosis of cancer has improved in the last years. And women, like all patients, are looking for a normal life after cancer. And a normal life for many, many women also implies having a child. Also because many of these women today that we treat today do not have children, do not yet have children. They want to have pregnancies in the future. On the other hand, probably oncologists were not aware that this was such an important point for our patients. And sometimes oncologists tend to exaggerate and consider that there are many of them that will not allow a woman to dye her hair while she's having chemotherapy. So you can guess what they think about having a pregnancy after chemotherapy. But anyway, as Bob Dylan says, times they are changing, luckily. There are several reasons why they are changing. As Federico said, the age at first childbirth is increasing. And for an oncologist, this increase in age means that the age of the woman tends to overlap with the age at which cancer incidence also rises. So this is a graph that shows how over 25 years, all over the world, because you see there is the United States, these are European countries, and this is Japan, all over the world. there has been an increase of almost 5 years in the age of the woman at first childbirth. And this increase, these are old data. They refer to 2006, so it's 15 years ago. And this trend is only increasing today. And as I said, as an oncologist, what we see is that when you increase the age of the woman, you also see an increase in breast cancer incidence, for example. And so if you take this part of the graph and you explode it, what you get is that if you just move from 25 to 29 to 30 to 34 years for the woman, you can see that the number of cases expected, these are data for United Kingdom published by Cancer Research UK, and you can see that the number of cases doubles or even becomes 3 times higher. So it really becomes a relevant problem, a relatively frequent occurrence. But as I said, the prognosis of our patient with localized breast cancer certainly improved over the last years. So this is a recent paper by Francis and by Olivia Pagani. And you can see here, these are just the women we are talking about, because these are premenopausal women with localized breast cancer. And as Federico said, this is the most frequent case that we see in our discussions between oncologists and fertility centers. And you can see that the overall survival at 9 years is over 90%. Of course, we would like to have 100% survival, and perhaps we will get there, but at the present time, I think we can be satisfied with this. And how long should we wait from the diagnosis? Well, again, for breast cancer, we can have a guess at how long to wait by looking at this nice graph by Yatoi, who published this, again, almost 10 years ago. And you can see that the hazard rate of relapse after breast cancer treatment peaks in the first 2 to 3 years. It actually changes according to different kinds, different histological types of cancer, but more or less after 3 years, you are already on the safe side. Because one of the points that we have is that not all women can afford to wait a long time, because female fertility is precious, but it's also vanishing. And so sometimes we have to do things as fast as possible. The techniques for fertility preservation have already been presented in the previous talk, so I don't need to talk about them. And I can go to the core of my talk. So when does the fertility clinic call the oncologist? Well, this mostly happens when there is a woman that is planning pregnancy and she has a personal history of cancer or a familial history of cancer. And of course, the concern is that this woman might have a relapse of her cancer or might develop cancer because of familial predisposition during stimulation, during pregnancy, or in the time following these phases. And what about the opposite side? When does the oncologist call the fertility clinic? This generally happens when there is a patient that is going to start chemotherapy and she, one way or another, mentions that she's interested in having a pregnancy in the future. The point is that the oncologist calls the fertility clinic and says, well, I have this patient and she would like to have to preserve oocytes or whatever system she chooses. But we have to start treatment as soon as possible. And this generally means that the chemotherapy is scheduled for the following day. And in many cases, the impression is that the oncologist doesn't really call the fertility clinic at all. So what is the problem? And the problem is certainly time. Because the oncologist has a patient with cancer and he wants to start treatment as soon as possible. And not only the oncologist, also the patient wants to start treatment as soon as possible. So often, even the patient will not be so strong in underlying her desire. On the right side, we have the fertility clinic, and they will need time to stimulate and to collect oocytes. And as Federico showed, certainly in the last years, the fertility clinics have made many progresses, so that, for example, with random start, they have dramatically shortened the time they require. But all the same, the result of this conflict on time is that the role of the fertility clinic is forgotten. But even if there is a problem, there is certainly a solution, and this is a good collaboration between the oncologist and the fertility center. The fertility center must be efficient, must be ready to see our patients at any time of the year. And so, is there a problem? Is time a problem? The point is that the oncologist should contact the fertility clinic not just when there is the diagnosis of cancer, when the histological diagnosis is ready, but already when there is a suspicious nodule. What I tell my colleague is, when you have a woman with a suspicious lump, whatever kind of cancer you suspect, contact the fertility clinic. Maybe later you will cancel everything. But if you do this, you have all the time, because oncologists are so in a hurry always, but you need to have a biopsy, to make a histological diagnosis, to make all kinds of biological examinations on the sample. And it takes time. And this time is the same time that the fertility clinic may need to collect oocytes. So this apparent conflict doesn't really exist anymore. And the patient and the oncologist will be able to start treatment as soon as possible. And at the same time, the woman will have her fertility preserved with one of the techniques already discussed in the previous presentation. And so this problem comes to a solution through collaboration between the group, even if, as Federico said, this collaboration is sometimes a bit difficult. So I hope we can discuss this point further. Please ask questions through the question and answer present in the Zoom screen. And otherwise, if you want, write a mail to this address, and I will be very happy to answer all your questions. It's been really a pleasure to talk to such a wide audience, to people connecting from all over the world. This has really been a very special experience for me. Thank you for listening to me.
Thank you very much, Dr. Codacci, and it was a really interesting talk. And we have many questions for you. And so I will start with a couple of them, and then we will continue later. One question, one person is asking, so if in the team of a fertility clinic, we should think of having always an oncologist, so directly in the team that we have seen before from Federico is quite very big and includes a lot of different figures. Do you think we should have an oncologist?
I think this depends on the kind of, on the population that this fertility clinic has. If they are, if they often deal with women with cancer, certainly would be important. Otherwise, if oncological patients only represent a small percentage, something like 10% of their activity, then it's much more practical to get in touch when it's needed. But what is important is to have that I must have the phone number of the fertility clinic, and the fertility clinic must have my phone number. So when one needs the other, we can call each other and get the best for our patients. Okay,
so you're suggesting like a direct line between the oncologist
yes.
and fertility clinic. And so similar on this topic as well is if you know anything about oncofertility experts in other countries. So do you know how this will work, because you have presented the situation in Italy and especially for you. So what about other countries? What do you know about it?
Well, for example, in the United States, this is a very relevant topic, but also in all European countries, as much as I know, there are Kelly Wallenberg in Sweden and Hatem Azim now. He's working, I think he's now working in Mexico actually, and all over. Also, I talked to Olivia Pagani, which is one of young women, and all these that I know that are mostly oncologists, they are all very involved in also in fertility preservation, because this is becoming really a very relevant topic, even if for many years, as I said, it was just ignored.
Okay. Okay, thank you. So we can now pass to our third speaker, Dr. Stefano Canosa, and he has a PhD in biomedical science and oncology, and he currently works as an embryologist at the Physiopathology of Reproduction and IVF unit in the Sant'Anna Hospital of Turin. He is a member of the scientific board of the Italian Society of Embryology, Reproduction and Research in the special group for vitrification and fertility preservation. His talk today is about the embryologist point of view in the fertility preservation. So thank you, and it's up to you now, Dr. Canosa.
Thank you very much for the invitation, also from all the members of SIERR Society, including the executive board. Hello to everyone. We'll discuss in the last part of this section the role of the embryologist in the IVF lab in the setting of the routinely performed cryopreservation techniques and also in the implementation of new biological approaches. Before starting, I just would like to declare that I have no conflict of interest in this presentation. As we have seen before, a fertility preservation program is based on a multidisciplinary approach consisting in the direct communication and collaboration between different healthcare professionals, belonging to the clinical care team and the fertility preservation team. This involves the common decision-making process aiming at offering the best care solution for patients. Among the fertility preservation group, specialized embryologists are involved in different cryopreservation techniques. Oocyte cryopreservation is the elective choice for fertility preservation in adult and young women, oncological women facing gonadotoxic therapies. To date, oocyte cryopreservation was demonstrated to be safe and effective for fertility preservation in this type of patients, but the long-term follow-up of the children born after this technology is quite limited. Apart from oocyte cryopreservation, we can also have embryos cryopreservation, but embryo cryopreservation is related to many ethical and also legal consequences, as embryos belong not only to the woman but to the couple. So if the couple separates or if the man does not consent to use the embryos, the woman is not able to have the pregnancy. So we can also have the ovarian tissue cryopreservation as an alternative strategies if there is insufficient time for controlled ovarian stimulation or for treating prepubertal oncological girls. Although this technology is still considered experimental in many countries. With the idea to set up a fertility preservation program based on ovarian tissue cryopreservation, it's important to remember that it's fundamental to identify one embryologist or more if possible, trained in ovarian histology, physiology, and freezing, and specifically dedicated to the cryopreservation procedure and to coordinate the whole process. The embryologist is also involved into drafting standard operating procedures, cryopreservation protocols, agreements with other clinics or services, and also the request to the local ethical committee. It is fundamental also to identify the most suitable equipment for freezing, the media for the cryopreservation protocols, and also the laboratory materials in general. The embryologist is also involved into sharing important information with other colleagues regarding the tissue handling, transportation, and storage. Finally, all the medical records should be accurately stored and then provided in case of inspection. I would like to share our experience with you about the collection of material from oncological patients in the so-called FertiSave project available at the Sant'Anna Hospital in Turin since 1997. To date, we have already collected more than 1,500 sperm samples, more than 400 patients who underwent oocyte cryopreservation, and more than 250 ovaries frozen in the last 20 years. To date, we have already performed 5 ovarian tissue transplantation, obtaining ovarian resumption in 4 cases and 1 spontaneous pregnancy obtained in a patient with beta thalassemia in 2012 and published 1 year later. Our fertility preservation program is based on a hub satellite model in which we hired hub clinic with the specific expertise in ovarian biopsy, cryopreservation, and storage, whereas our satellite clinics are involved into biopsy and the transplantation of the tissue in specific culture conditions, in particular in conditioned medium and 4 degrees, so on ice, within a limited time period of 24 hours. And our satellite clinics are located mostly in the center and northern Italy, so there is enough time to reach our clinic in order to perform a good cryopreservation. Hub and satellite clinics collaborate usually by a formal agreement, so they also share common protocols and documentations. Prerogative of the hub clinic is the whole availability of the professionals performing cryopreservation freezing. This means 365 days per year, as normally ovarian biopsy is scheduled on beforehand, but urgent surgical intervention may happen every day. Moving into practice, the ovarian tissue comes from the operating theater on ice, and once at the laboratory, the ovary is cut in 2 in order to expose the medulla, which is immediately removed using pincers and a scalpel blade. Then the cortex is cut to generate fragments of 5 mm in length, 5 mm in width, and 1 mm in thickness. According to the total number of fragments that we can generate, we will produce and split the fragments into 4 types of cryovials. So we will have cryovials containing fragments available for the transplantation, maximum 6 fragments per vials. Then we will have 1 or 2 fragments used for the towing test before scheduling the ovarian tissue transplantation, and then 1 or 2 fragments plus a portion of the medulla used for the fresh histological evaluation. Then the fragments are exposed to the cryopreservation media, and the temperature is cooled down using a computer-controlled freezer following a slow freezing procedure. At the end of the process, the samples are then stored into liquid nitrogen, and the medical records are collected. The entire procedure requires approximately 3 hours, in which the embryologist is completely dedicated to the process, so not available for the rest of the activity of the IVF lab. So one of the first points to take into consideration before setting up a fertility preservation program is to organize a cryobank inside the IVF lab with enough space to collect the samples. As previously mentioned, so apart from the cortex and the medulla are used for the fresh histological evaluation. So we will evaluate the primordial follicle count and also the minimal residual disease according to the specific diagnosis of the patient. And this is made thanks to the close collaboration with the pathologist of the anatomical pathology unit. The same analysis is then repeated on the third cortex just before scheduling the ovarian tissue transplantation in order to evaluate the survival of the primordial follicles and also to exclude the contamination from malignant cells. In fact, it has been observed in around 20% of non-gynecological diseases that there is a contamination from cancer cells within the ovary. About the transplantation, to date, consensus is lacking regarding the number of fragments to thaw to optimize the chance of pregnancy. According to our clinical practice, we usually thaw a minimum number of 10 fragments following a rapid thawing protocol. And at the end of the procedure, the embryologists move directly to the operating theater in condition using a sterile tube with the cortex in conditioned medium at room temperature. And at the operating theater, the transplantation is performed using a novel surgical solution that was introduced by our group some years ago, consisting in an echogenic surgical thread, which is used to generate a chain of cortical fragments. This chain is replaced and tied into the ovary, and the surgical thread is used as a marker to evaluate whether the follicular growth and the ovulation occur within the transplanted ovary or in the remaining ovary. Also, in this case, the entire procedure requires approximately 3 hours in which the embryologist is busy and not available for other procedures for the IVF lab. One important point about ovarian tissue cryopreservation is that success is very difficult to determine, as transplantation may occur several years after freezing. So it's important to define quality assurance and quality control measures in order to coordinate all the phases of the process. One solution can be to generate a checklist like this one proposed from the Danish group, controlling all the phases of the process. So before freezing, during the freezing, and also before and after the transplantation. Another controversial point is represented by costing, especially in a public setting. As we can see from in this table from the fertility preservation guidelines released only a few months ago, in some countries there is no or limited coverage of costs regarding the fertility preservation techniques, whereas in other countries there is a complete coverage, so no of the costs, so no costs are applied to the patients. And this heterogeneity is related to many factors, including the age of the patient, the diagnosis, the prognosis, and also the number of cycles that the patient can undergo. In our case, in Italy, we have a regional refund of 500 euros per procedure, just to have an idea of which is the cost of a single procedure of ovarian tissue cryopreservation. So now moving forward to the future, to have an overview of the ongoing developments in fertility preservation cancer patient, we have to mention the improving and the freezing protocol starting from the vitrification, as vitrification is less time consuming and is independent from the use of a computer controlled freezer like the slow freezing protocol. In addition, vitrification was demonstrated to better preserve the morphology of the follicles and also the ultrastructure of the stromal cells. More recently, also slash nitrogen vitrification was introduced and suggests to further improve the vitrification protocol. But however, to date, the number of live births after vitrified ovarian tissue are very limited. So the vitrification of ovarian tissue should be suggested only within research programs. Oocytes in vitro maturation is another alternative, and is suggested when controlled ovarian stimulation is contraindicated or when the time for controlled ovarian stimulation is very limited. In this case, data available in literature are mostly related to maturation rates of the oocytes rather than fertilization rates, embryo quality, and embryo implantation potential. So also in this case, this technology should be considered as innovative rather than established for the clinical practice. But the most drawback of ovarian tissue cryopreservation is represented by the low number of viable follicles during transplantation. And this is due to many factors, including the removal of the ovary from the oxygen and blood supply during the biopsy, the tissue manipulation, and also the freezing and thawing protocols, but also the ischemia occurring during the transplantation. And in addition, we have also discussed the problem of cancer contamination within the ovary. So in order to limit follicular loss and also to exclude cancer contamination, the implantation and grafting of isolated ovarian follicles has been suggested. In fact, human follicles can survive and grow for 1 week after xenograft if enclosed in plasma clots in mice. A further improvement of this approach may lead in the future to the so-called artificial ovary, in which the isolated follicles are enclosed into biomaterial scaffolds with the addition of growth factors, endothelial cells, and ovarian stromal cells, and then replaced into the ovary. In this case, the follicles may generate new mature oocytes, and the granulosum theca cells within the follicles may produce sex hormones. Finally, a population of ovarian stem cells has been recently identified within the ovary and has also redefined the paradigm of the fixed pool of oocytes present at birth. In the mouse model, the local injection of the ovarian stem cells can produce new follicles, and once isolated, these follicles can generate oocyte-like cells in vitro. Also in humans, ovarian stem cells can be differentiated into oocyte-like cells in vitro, and more importantly, this process seems to be completely independent from the hormonal stimulation, thus providing in the future a new strategy to preserve fertility in oncological patients, which is completely independent from the use of gonadotropins. So to conclude with the idea to set up a fertility preservation program based on ovarian tissue cryopreservation, it's important to remember that dedicated professionals are recommended with specific training obtained visiting other clinics with hands-on, and this is important especially in the first cases of the procedure about the cryopreservation. Overall, due to the limited number of ovarian tissue cryopreservation performed worldwide, it is suggested to concentrate the procedures according to HANAB satellite model that we have seen before. And finally, about novel technologies that are now under investigation, it should be concluded that further validation is now needed before their introduction in the clinical practice. So I would like to thank all my colleagues of the Physiopathology of Reproduction and IVF unit of the Sant'Anna Hospital in Turin, who are daily involved in the fertility preservation program. Thank you for your kind attention.
Thank you. Thank you. Thank you so much, Stefano. Great job. So we got some questions from the audience, and one is probably from a person from the USA, and is asking, just because during pandemic lockdown in the spring in USA, the oncological cases were considered as essential medical procedure, even when IVF centers were closed. So they is asking if was it the same situation in Italy. So did you work during the lockdown in your clinic?
Yes, absolutely. So our clinic was closed for the normally routinely performed IVF cycles, but we were open for all the oncological patients. So we continue with the freezing of sperm samples, oocyte samples, and of course for ovarian tissue. So the situation was exactly the same. We consider this procedure as urgent.
Okay, so I have another quick question for a quick answer. Then we go to the session for the question and answer from 20 minutes. And the time to reach the lab from the ovarian issue harvest, how is it critical and what is the maximum time? Probably you said already, but just to underline.
This is an important point. So when we collaborate with satellite clinic, we try to stress the importance of the time, the limits of time period is 24 hours. It's our limit time period. But as I discussed before, our satellite clinic are located within 3-4 hours from us. So 24 hours should be considered the maximum time period without affecting the quality of the tissue.
Okay, so Francesca, how is?
Yes. Well,
do you want to
yes,
ask some?
I'd like to ask actually a quick question on what Stefano was saying. So will the patient have the cortex, the ovarian cortex, for example, removed in the satellite clinic, and then the tissue will reach your unit, or the person has to move from where she is to your clinic in Turin?
We can have both the situation. If the patient prefer to stay in his own city, it's possible to arrange with the satellite clinic to perform the ovarian biopsy, and then we arrange the transplantation of the tissue from our clinic. Otherwise, if the patient prefer to come to Turin, in our cases, we can do the biopsy in our clinic. So we can have both the situations. Okay,
thank you. So now what we will do is we will ask questions to the three speakers in turns. So going back to Dr. Cirillo, they are asking, are you there? Yes?
Yes, I am.
Okay. So they're asking, what day can a stimulation protocol start? And what is best in your opinion, if you have a preferred day to start?
As quick as you can.
Okay.
So
a quick answer.
in the first day that is possible to perform it, in order to minimize the delay before the chemotherapy or the oncological therapy of the patient. I think that we demonstrate how it's not so dependent on the day that in which you start. So it's better to start as weak as you can.
Okay, thank you. And instead, Estrella Rosenberg from Caracas, she is asking, when you do the egg retrieval for cryopreservation, do you only cryopreserve the eggs that are mature? And if you have a small percentage that are mature, how long do you wait to do the vitrification?
No, we cryopreserved also GV or immature eggs.
Okay, so
in order to maximize the number.
Okay, thank you.
Giovanni, we have a question for you, and the question is just because more and more patients where women can survive the cancer. And if you have an index of quality of life post-cancer, you can tell us, what do you think if the after treatment, the fertility preservation should or should not be proposed to all the sufferers?
Of course, this is a point to discuss with the patient, and it's important to be careful, because what happens is that at the moment of the diagnosis, generally the woman is terrified, and because the word cancer in most people means I will die within 1 week or something like that. So these women will refuse to look to something which will take place in 2 years or in 3 years, because they are too terrified. So what is important is not just to ask once, but to talk to the woman and then to ask again. As I said, what is important is that we may start thinking about this, not just when we have the histology report saying that this woman has a cancer, but already if we have a reasonable suspicion that this woman may have cancer, and if she is in an age when she might be interested in a pregnancy, in preserving her fertility, I think this is important. And it's something that should be discussed with the woman. I think one of the most important papers we published with Federico Peccatori was not in a scientific journal, but it was in a journal which is called in Italian Acqua e Sapone, which you probably do not know, but it is the magazine of a company, of a beauty company, because women do not read the New England Journal of Medicine generally, except Francesca, of course. But women read these journals, and they are the first that must be informed. They must know that this is something which is possible. And then they will ask the oncologist. And so I think we must push on both sides, on the oncologist, but also on the women, and make it clear that this is something which is possible, that will not compromise their prognosis, that will not cause any problem to the child, because these are the main points that must be made clear to everybody.
Thank you, Giovanni. So Stefano, now is a question for you. You already touched that point, but is a practical question, so please try to answer. The question is, ovarian tissue is usually done by slow freezing procedure. How does that affect your normal IVF routine? You have to wait for theater, prepare the tissue and freeze and store the sample. So do you think that you need a separate equipe of person, or you can manage everything in the IVF team?
We can manage, regarding the space, the physical space, we can try to manage all the procedure within the IVF lab. But as I have previously mentioned, it is important to remember that the day of the cryopreservation or the date of the thawing, one embryologist should be completely dedicated to the process. So he is not available for the other procedure of the IVF lab. So about the laminar flow, about the plastics and the physical environment, we can manage everything within the IVF lab. But about the keep, we have to take into consideration that one embryologist is busy for the procedures.
All the time.
Thank you.
Francesca?
Sorry, I was reading the questions. So I have one question that actually is either for Federico or for Giovanni. because they're asking from the audience, do you start with antagonist in the same time? Breast cancer patient do all letrozole. So who wants to answer is welcome. Maybe Federico.
I can answer to the letrozole part. We use letrozole for breast cancer patient. Even it's still a big matter of debate if the letrozole is useful or not, but we use it.
And so instead,
may I?
Yeah, of course.
I don't know what they mean when they when they say do you start with antagonist? Perhaps he means using LH-RH analogs to preserve fertility. This is something that we try to do before we start chemotherapy. So we start inducing menopause, after all, at least 3 or 4 weeks before we start chemotherapy. So we are more confident that the ovary is actually at rest, and so the protective effect might be more effective.
Okay.
I think it's also referring to the possibility to start the antagonist for 5 days, like a random start. You start with the antagonist for 5 days, and after that, after menstruation, you start with the follicular phase, traditional stimulation protocol. We use it sometimes if in cases in which you have, for example, big corpus luteum, or in which the estrogen and progesterone levels are higher, and you think you cannot achieve a good number of oocytes. So we start with 5 days of antagonist, and after that, at the menstruation, we start with the cycle.
You think always, Federico, do you think always 5 days of antagonist or even 3?
No, it's not fixed. I think in majority of cases we used 5, but I think there is no clear indication between 3 or 5. What do you use, Andrea?
I do 3 days for when I perform double stimulation. So it depends which because here is not for double stimulation, but it's just the random start. So it depends in which part of the follicular or the secretive phase you are. So could be different. We have another question for Stefano, that please try to synthesize, because people want to know something more about the slash nitrogen.
Okay, the slash nitrogen is a new technique that was suggested by Professor Riccardo Talevi in Naples, in Italy, and it is a technique in which the liquid nitrogen is exposed to a high pressure in order to generate a vapor of liquid nitrogen. And this allows to perform a better preservation. In fact, in the papers published by Professor Talevi, it was demonstrated that the ultrastructure of the tissue and the morphology of the follicles within the ovary are better preserved compared to the standard vitrification protocols. And also regarding the molecular point of view, also the analysis of the apoptosis of the granulosa cells and the metabolic pathways are better maintained during this strategy rather than the standard vitrification. But it's still under investigation, so within research programs.
Thank you.
Okay, thank you. I think then one really quick last question for Stefan again, and then we will close this session, not to make it too long. And so they're thanking you, saying a great talk, Dr. Verma. She would like to know, or he would like to know, sorry, what is the temperature in degrees Celsius you maintain for transporting the tissues? And then on ice only?
It should be between 2 and 8. From the range should be from 2 to 8, but the idea should be on 4 degrees, so on ice. Yes.
Okay. Okay, thank you. So thank you, everyone. This was a really great session. And so I would like now just to conclude. First of all, I would like to thank the speakers and even the moderator. So I would thank Dr. Ubaldi and Dr. Borini. And then Dr. Cirillo, Dr. Codacci, Pisanelli, and Dr. Canosa for their really great talks. Also, we need to thank the organizing committee of this initiative, and in particular, our thanks goes to Peter Nagy, Thomas Elliott, Shaista Sadruddin, Giles Palmer, Jacques Cohen, Mary Ann Zvatas, and Colin Howell. This is they go through a tremendous amount of work that goes behind the scene and not everyone can see, but really is a great effort they are doing. So again, thank you. There also a team today that has followed the session, and they are Marianne, Giles, Anne, Kelly, and Shaista. So again, thank you for helping us today and make things go smooth. The session and the presentation will be available online soon. So for those that would like to go through again, there's this possibility. And this is thanks to Thomas Elliott that arranged all this. So before closing this session, I would like to remember the following session that please do not miss. It will be next Tuesday, the 17th of November at the same time. And this session will be sponsored by TMRW, and the title is Cryo Governance, a session towards good practice guideline in cryo storage and cryo transport. So thank you again, everyone, and good night, goodbye, good morning, wherever you are. Okay, thank you, everyone.
Bye.
Thank you, Francesca. Bye.
Ciao, ciao.
Ciao. Ciao
Thank
to
you.
everybody.
Bye.
Bye.